Well, I'm very happy to be here today, and I will start by saying that about 10 years ago, I had some kind of existential crisis because I had been working in understanding the disease, atherosclerotic disease, and I realized that we knew more about this disease than we knew about health. So I decided to move completely towards health with the same sophisticated technologies that we use in disease. This is why the title is Transition from Cardiovascular Health to Cardiovascular Disease. And Imagenomics, because these are two technologies that we have used, imaging and genomics, throughout the lifespan. I will talk from birth to age 100. And the question is, we are dealing with the #1 killer today, atherothrombotic disease, and in fact, it's a systemic disease. It's not just coronary or cerebral. And I have here a subtitle, From the Legs to the Brain. So let me move into the situation we are talking about. Here, as you can see, in the bottom is how we started to understand myocardial infarction. And we all realize over the years that we have about 8 risk factors that were very well known. I tell this because there are some medical students here that would be also important to realize the issue that is killing people today. 2 of the risk factors are mechanical, high blood pressure and obesity. 2 are chemical, cholesterol and diabetes, and 3 are behavioral, smoking or lack of exercise and poor diet. And then the last one is a poor sleep, either short sleep time or intermittent sleeping. Well, all these risk factors traditionally have been thought that they affect the layer of the heart, of the coronary arteries and of any arteries, the endothelium. And then by being damaged, cholesterol enters into the artery and so forth. Well, things have changed, as you will see in a moment. But anyway, we decided 10 years ago to move from here to here. And this is how the disease develops. And then we decided to divide the population in 3 groups, from birth to age 20, age 20 to 60, and age 60 to 100. And then we decided also to use the most modern technology available, imaging and genomics, artificial intelligence, new therapeutics, we'll talk, and then the genetics of a particular cell that circulates in blood, the monocyte, which is very important in the disease that we are talking about, atherothrombotic disease. So having said this, now comes the issue. What is the challenge between age 20 to 60? I think all of you will agree the challenge is I am developing the disease or I am not. It's as simple as that. The #1 killer. I am developing arterial disease or I am not. So we decided to approach this by simplistically developing technology that was external to the body. And I will show you this in a moment. Imaging technology with ultrasound. But before I go any further, I will tell you that the challenges in these 3 different ages, we have 4 findings that I think may be of interest to you in each of these ages. So let me go from 20 to 60. Well, about 14, 15 years ago, we developed the so-called PESA study in Madrid. This is part of the CNIC institution. And in this PESA study, what we did is to look at over 4,000 people, apparently normal, between age 40 and age 54. We are following these people for 20 years, every 3 years. I'm going to start presenting imaging technology in these 4,000 people. Ultrasound, CT, MR, positron emission tomography, etc. And look at what is the relationship between the disease that is developing and the risk factors that we are talking about. Now let me move into the 4 findings. Here, finding #1. We have over 4,000 people, as you can see here, age 40 to 55. High incidence of subclinical disease with ultrasound. What we really worked was in ultrasound of the 2 carotid arteries, of the main aorta, and of the 2 iliofemoral arteries. And then we use CT scanning to address calcification of the coronary arteries, an indirect way to address coronary artery disease. Perhaps surprising. Here on the left, you have males, and here you have females. And in males, you have that on the age of 50 years, 2/3 have already one of the territories that I mentioned with disease. Here you have a second group, 2 to 3 regions with disease, 4, 5, or 6. We are talking again 2 carotids, 2 iliofemorals, the aorta, and the coronary arteries. Well, so a high incidence in males, 2/3, under age of 50 years. In women, just half. Well, so was this surprising? Was not, because we know about the Vietnam War, Korea War, and we know that young people at autopsy already had disease at young age. But this was with imaging, ultrasound, that we developed 3D ultrasound. But there are 3 other findings, and that is the disease you will see begins in the legs, progresses at about 33% of the individuals develop disease, progression of this disease at 6 years of follow-up, and the importance of risk factors at young age. Let me say a word about each of these. The disease starts in the legs. Very interesting, isn't it? Because we all think it's the heart and the brain. No, the legs, 71% of the disease starts in the legs, in this region. And this is in males. In women, 48%. So this is interesting because claudication is very rare, except later in life, but not at the beginning. And what happens is the arteries are very large, and therefore you may have atherosclerotic disease developing, but certainly there are no clinical manifestations because the arteries are big. On the other hand, in the heart, the coronary arteries are small, and so a little bit of disease can cause already symptoms. This is very interesting. Well, the progression of the disease, this was actually published this week, and that is, we look at the, in the abscissa, you have the baseline at time 0, and these 4,000 people, and we measure atherosclerotic disease by cubic millimeters externally. And this is the ordinate, the follow-up at 6 years. So 33%, the disease progress, and in near 10%, the disease actually regress. This is a mapping examples that we have from baseline, no disease. Here you develop already the atherosclerotic process, and here's the opposite, the issue of regression. And this is actually what I'm commenting on about these issues. Well, this is very fascinating to me, and that is the age. For example, a high LDL cholesterol at age 40 had much more influence in the progression of disease than at age 50. So what we found, earlier you are on a risk factor, higher is the impact of the risk factor. We found the same with hypertension. This is very important because we tend to think that somebody at age 60, very hypertensive, this is a huge risk factor, but you don't know that the worst part was between age 20 to 40. I have more data to present to you. So in fact, we are so primitive when we think about this disease because we didn't have the technology to see the subclinical disease. So all of our guidelines and so forth were based on heart attacks, strokes, but this is already very late. I'm talking about something quite different. That is the beginning. Well, this is part 1 of this PESA study on these people. But here's the question. If risk factors at young age play a role in the progression of the disease, what about in the events later on? So what we did is we went into the cardiac study. The cardiac study is between age 20 to 40, you have here, and over 4,000 people between age 20 to 40, the abscissa, LDL cholesterol fluctuates. So you can have an area here. You measure this area, and then you say, what happened 40 years later? And we have the data. In fact, we just published this. This is actually HDL, blood pressure. The results are very, very interesting and perhaps surprising. Here's what happened 20 to 40 years later. Higher is the burden of disease by just measuring the area. Between age 20 to 40, higher is the actually event rates, heart event rates, heart attacks, strokes, and at the 20 to 40 years later. This is for LDL cholesterol, triglycerides, blood pressure, and so forth. So I'm not explaining to you something trivial. What I'm presenting to you is our children at age 20 to 40, and I have much more to say between birth and age 20. are really when the disease is cooking, and we didn't pay attention because we didn't have the technology available. So having said this is the second finding, which I think is quite interesting, how the risk factors not only play a role in progression, but play a role later in life. And this is the third finding. If you go to guidelines today, and you look at LDL cholesterol, for example, here, this is normal. Between 80 and 110 is normal LDL cholesterol. Normal by guidelines, but not by subclinical disease. Look at this. To be free of subclinical disease, you have to have an LDL less than 70 milligrams DL. You say, well, that's fine. What about the rest? Well, this is what is happening. Now, let me talk about diabetes here. This is what we call pre-diabetes. And pre-diabetes is considered an alarm system for diabetes. I don't know if this is an alarm system. Look, the amount in color is the amount of the subclinical disease that is present in something that is called an alarm. But what about even before pre-diabetes, insulin resistance? We just measured this. In fact, this is going to be published in a couple of weeks. This is insulin resistance. Before pre-diabetes, we already have significant subclinical disease. So what I'm saying to you is that prevention and promoting health is so critical, but is becoming critical because technology may open our eyes of what really is happening. And this is a complete change in the way we were educated in the cardiovascular field. Well, this is point number 3. This has led us to develop the first trial at young age. The pre-cut trial is starting right now. This is a study of people between age 20 and 40 that have an LDL cholesterol more than 70 milligrams DL. So we consider this abnormal. These individuals, near 2,000, are going to be randomized into very active treatment to bring the LDL cholesterol below 70 and the other risk factors appropriately. And the other group will have a standard care. Follow-up 5 years, although we plan to go to 20 years, but this is the beginning. 5 years of follow-up. The primary endpoint is, are we preventing progression of the disease if we treat these young people appropriately according to subclinical disease to get LDL cholesterol levels less than 70? And actually, we already have preliminary data. We are using inclisiran, which is subcutaneously, to give a lipid-modifying agent twice a year if statins or ezetimibe or others have not have done the job. So, but many of you may say, I am skeptical. The progression of disease, because these are young people, is really a good endpoint. And you say, I would like to see events. Well, no, there are not so many events at age 20 to 40. So now I'm going to tell you that you should not be skeptical because I'm going to be presenting to you some interesting data here. This is a study with the same technology. We have not published this yet, but between age 60 to 100, near or more than 3,000 people. And what we did, this is older. So you are dealing already at time of events. What we did is for 10 years, we follow these people. Well, who progressed, who didn't? And then we measure 3 years, 4 years later, who had events, who didn't. And the results were fascinating. Look at here. This is the group that the disease was progressing from age 60, 65. And these are the events that took place. And this is the group, the disease was progressing less. This is, we measure progression here, where the events were less. So the statisticians of the pre-cut study says, don't worry, because you are dealing between age 20 to 40, but if you find an area of disease and progression at that age, this means events. And even we could predict the events by the data I'm presenting to you. Again, pointing out that everything starts earlier in life. And having said this, there's a fourth point that I want to make. And what about genetics? Very fascinating. So here we go back. I presented to you some aspects of imaging and risk factors. What about genetics? And this is actually very interesting. This is a study by one of the colleagues in Spain who is working with us, Devesa, who did positron emission tomography to see what happens with the bone marrow when the disease is active in the arteries. And this is actually positive emission tomography in blue. This is the bone marrow, which actually coincides with this yellow material. You know what is this? These are monocytes from the bone marrow that are taking care of the cholesterol that has been depositing there. Well, this being said, if you leave this room today understanding this slide, I feel very happy, because this is critical, is to understand acute coronary syndromes, heart attacks and strokes. Let me start here on the right. 900 people, positron emission tomography is a war between the substrate that is cholesterol and the bone marrow that has the monocytes. And the monocytes try to take the cholesterol out, which may work, and we call this compensated. For example, a smoker stops smoking, and then what happens? The monocytes get the cholesterol out, and there is a stabilization or regression of disease. Very nice. Now you continue to smoke, the arteries are being damaged, cholesterol keeps entering, and the monocyte commits suicide. Apoptotic phenomena. What that means is when the monocyte finds too much substrate in the artery because risk factors have not been modified, the monocyte reads there and says, I cannot do the job. And the apoptotic phenomena is terrible in biology because you kill yourself, but you release substances that kills everything around it. And actually the substances that are released here are tissue factors and metalloproteinases. And that is when these cells decide to commit suicide, they break the artery at the level of the cholesterol by the metalloproteinases, and tissue factor is being released, which causes the blood clot. So I will tell you, and I don't like to say that, but I got the Príncipe of Asturias Award exactly by what this red I am presenting here. And that is what happened is that acute coronary syndromes is the war is actually won by the substrate. It's too much. And the monocyte kills itself and releases everything that leads to the acute syndrome. This is very important. And I started many years ago to talk about platelets, and this was part of the hematologies. Today I'm talking about the bone marrow. You will see the importance of the bone marrow in 5-10 years, because that's the key of what is happening in this war between the substrate of risk factors and the defense mechanism. Well, now something more interesting. It has to do with genetics. And I'm going to talk about two types of genetics, the so-called CHIP and epigenetics. You know, CHIP, actually, we published the first study actually in 2017. And what happened is the bone marrow that sends the cells to the artery, if there are mutations, these cells don't work. So you have substrate there, cells come in, and they're not good. These are mutations. This is called CHIP, the hematopoietic cells from the bone marrow. And then we have the issue of epigenetics. So let me start with CHIP. We just finished the study in the PESA, and I can tell you very simply, 20 to 35 of healthy middle-aged individuals carry detectable mutations of the cells from the bone marrow that they are not doing the job. So when you hear the patient had a heart attack and I don't find risk factors, I can tell you we are beginning to see something very interesting. A huge risk factor are the defense mechanisms in failure because the mutations I just mentioned. I could talk about TT2, DNMT3A. I don't want to just spend time on this, but just on the concept. And that is, we are now beginning to think that genetics are important in this disease, not only because hypercholesterolemia, high Lp(a), but also by the cells that are released from the bone marrow. And in fact, the data that we have is these mutations precede the progression of the disease in the PESA study, which is fascinating. Well, What about epigenetics? You know, epigenetics is the genes are transformed by some external factor, and that is you make a gene different. Epigenetics. The most important aspect of epigenetics is actually the issue of DNA methylation. And now I'm going to tell you a concept that at the present time is creating a revolution, and that is chronological age versus biological age. Somebody is age 70 and looks like having age 50, but somebody is age 70 and appears to have age 90. And what really counts is the biological age, not the chronological one. And this is now beginning to be understood. Well, basically, external factors, a number of factors, can affect the cells of the bone marrow, and the DNA is methylated. Well, let me just give you a piece of information that is very fascinating. I told you at the beginning that the risk factors may damage the endothelium and the cholesterol enters. I think this is partially true, but there's something much more complex. Look what we found with the positron emission tomography study that we did. When the bone marrow is activated, and look, the bone marrow is activated with the quartile in the metabolic syndrome, central obesity, hypertension. And now we are finding that this causes methylation of the cells that I was talking about. And the inflammation is very aggressive when there is methylation and shortens life. So now we are beginning to understand something, that the risk factors not only play a role by damaging the artery, but they go to the bone marrow and they appear to affect the biological clock. And this is actually was published just a few months ago. And this is the concept that I'm presenting to you very interestingly, is that the bone marrow, when there is methylation and risk factors, the inflammation is very active. And then you can actually cause disease, not by a defense mechanism that is failing and you don't have a defense, is because the inflammatory process is so active that destroys the artery. So we are now beginning to understand genetics, and I want now to pause for a moment and just summarize what I presented to you, which is all for the last 2 years. First, imaging of external arteries or systemic disease is critical. And actually, we go to poor countries and we are using the ultrasound in the legs. We don't check the blood. We just look at the risk factors, no cholesterol, no diabetes, but we have obesity, we have hypertension, and you can have in half an hour a real issue of the risk. And I don't have any question in my mind that when we look at predictability of cardiovascular disease, arterial disease in the future, is going to be through very simple imaging technology, which will be available, by the way, to the public in the next couple of years. And then the risk factors I mentioned. Second, early identification of disease and risk factors earlier in life. I show you this, and this is critical. Third, if you think you're developing the disease because you show the arteries a subclinical disease, early risk modification can take place. And this is what the pre-cut study is trying to show, that in this fight between the bone marrow and the substrate, actually the bone marrow is the winner. This is the pre-cut study, and LDL cholesterol is more than 70. But even without any pre-cut study, what I'm really showing is that in the future, at age 20, 30, an ultrasound will be done, and those at risk have the chance to change the health style and so forth. This is what is important. And finally, I mentioned genetics. New aspects of genetics that to me are very critical. The issue of CHIP. The bone marrow is not working well. These are mutations. Or epigenetics. The bone marrow is hyperactive and the inflammation can damage the arteries. This is basically the summary of this first part of my presentation today, which is what is the challenge between age 20 and age 60. Now, with all this new technology, what about the challenge in the brain? 60 to 100. I will start by saying that to me, the main challenge at that age is cognitive dysfunction in Alzheimer's disease. So let's see what one can learn with all this new technology. Well, first of all, let's go back to Alzheimer, here on the left. More than 100 years ago, interestingly, this pathologist said, my disease is a disease of the arteries that supply blood to the brain. And here the question is, how is possible that in 100 years, we have been trying to go against the cell, the neuron, and trying to see if we can modify the deposition of beta amyloid and other substances there. And the arterial system has been forgotten. Well, one have an explanation for that. If you have cognitive dysfunction with Alzheimer's, for example, it's logical to think that the neuron is involved. So that's where the whole research has been focused. But there was no technology to see the arteries except Alzheimer's, who was a pathologist. So having this in mind, I'm going to be presenting to you now very interesting data of a study that we started, transatlantic study between New York and Madrid. It's a so-called CNIC study I mentioned. And basically the hypothesis that was elaborating then in 2020 was the following, that when you have risk factors that are affecting the large vessels, as I mentioned before, maybe there is microvascular disease of the brain. Maybe the pathology suggests that, hypertension, hypercholesterolemia, diabetes. If this is the case, can we measure it? Measure it by what? Flow with MRI. We have that technology. Second, if the flow to the brain is decreased, there is less uptake of glucose. We can measure that with positron emission tomography. And finally, if there is less glucose entering the brain because there is a decrease in flow and uptake, what about cognitive function? Well, Alzheimer's disease, I put it aside at this moment. But these are the findings. We measure cerebral blood flow with MRI, and in 96 individuals, 59 were women. And if they had hypertension, very high cholesterol, or diabetes untreated, this is by mapping. The color means decrease in flow to the brain. Then what we did is positron emission tomography to see if there is less entry of glucose in the brain when the circulation is decreased because of the risk factors are affecting the microvasculature. And that's what we found. This is the Framingham, more risk factors, less entry of glucose in the brain. Here is blood pressure. And as you see, the blood pressure is untreated, more risk factors. Is blood pressure in this case, less uptake of glucose, which is in red. This was published 2 years ago, but we have very new data we'll present in a moment. So this is number 2. And number 3 is, if you have hypoperfusion of the brain detected by MRI, arterial spin labeling, and a decrease in glucose, is cognitive function being affected? We don't know the answer at this moment. We use MoCA, which is actually a standardized way to look at, cognitive dysfunction. And we don't want to talk too much about it. I think it's being affected, but we don't have strict data to present it. Well, this is the third experiment. But the question is, in any investigation, there is nothing perfect. I remember that my first publication took 4 years to be done because I wanted to be perfect. And I realized you can never perfect in anything you write. And this is an example. These patients I presented was not the same individual who had decreased circulation, uptake of glucose being decreased cognitive dysfunction. We're different individuals, but fulfilled the hypothesis, all had significant risk factors. Now, what I'm presenting to you is that we developed now the 4th study, the prospective heart-brain axis, which is every individual, 1,000 of them, mean age 55 years, 60% men, they all follow all the technologies I mentioned. Not only that, In the heart, we measure troponin, but now we have new biomarkers that tell us when the brain begins to be affected. Well, this is fascinating, and actually the first paper was presented in The Lancet just 10 days ago. And I don't want to go into too much detail, but what we are showing is that in patients who have significant risk factor profile, this is baseline, this is the glucose uptake in the brain, is significantly decreased. I could go into lots of details of the paper. I only want to stay on the concept here. And that is, there's no question in our minds that we have a disease that starts at early age, but is affecting the brain from the very beginning. And we don't realize that until age 40, 50, 60, when you begin to see cognitive dysfunction and things that are happening. This is what I'm presenting to you today. Well, there are two issues that perhaps I want to add and are of interest to this. One is this study that was actually a review in 2023 that we have in the British Journal of Pharmacology. In an experimental model of Alzheimer's, now let me move to Alzheimer's, we have small blood clots in the microvasculature that can be prevented by anticoagulation. And actually, it's beta amyloid is hypercoagulable. And here's our question. When Alzheimer's said my disease is a disease of the arteries, was he talking about the risk factors I mentioned, conventional, affecting the microvasculature? Or he was talking about clots? He never wrote what he saw. He just said it's a disease of the arteries. I only present this to you because two issues about Alzheimer's. First, these findings, which is interesting, and we are now looking at the possibility of anticoagulation in people with a strong family history for Alzheimer's, but we are worried because these people have more tendency to bleed. So we have to be very careful, and we are looking at this. But there's a second issue. The pictures I presented to you today about the glucose uptake is interesting that the main areas that are affected are the areas where Alzheimer's disease actually develops. That's why the paper was published about a few days ago. So what we are thinking is that Alzheimer's is a specific disease of the neurons, but is in a way, the speed of the progression of the disease has to do with arterial disease. And we are not entirely sure if clots play a role or not, but probably the risk factors play a role also in the progression of Alzheimer's. Well, second aspect is, this was just published by other investigators in Science just 4 weeks ago. And the heart-brain connections, they are talking about everything I'm presenting to you today. And that is, my friends, we are cardiologists, many of us here, but it's better we pay attention to the brain. Because in the present society, there is more concern about the brain than the heart. In fact, I had 2 patients last week. Both said the same thing. Doctor, you're a torture. You want me to drop blood pressure, to lose weight, to stop smoking? Do you think this is life? I prefer to die suddenly, they said. And I said, well, my friend, I'm not sure if you are going to die suddenly or not, but let's talk to the brain, you and I. I did this with both of them. And I said, do you know what happened to the brain is a progressive disease? There's nothing sudden there. They completely change. I am not sure the follow-up, but what I tell you in the practice, they both felt, you know, maybe it's worth it we take care of ourselves. So what I'm really presenting to you is that we are in a new era. It's the era of understanding health and prevention, and start as early as possible, because we have missed all of this. Maybe we didn't have technology, or we all have so many patients which we have to continue to treat appropriately, that we don't think about what evolved previously that might have been prevented. Well, having said this, now I want to pause 2, which is the second area I mentioned. The first 4 already mentioned to you was the first part of my presentation, age 20 to 60. Here, brain imaging and biomarkers in the future, I'm not sure. Maybe expensive, and I'm very worried about that. But certainly, cardiac patients may become sensitized to the brain in the way that I'm presenting this to you today. And that is better I take care of myself, smoking, cholesterol, hypertension, and maybe good to have a better brain in the future. Well, this being said, This is the third part of my presentation. They gave me 45 minutes, and I never want to be 1 second more. I have 10 minutes here. And this is the most important part of my presentation today, and that is education. You understand it. The science is important. Let us more and more earlier and earlier. But the question is, what in the world you do? And here's my point about primordial, not prevention, but promoting health in children. The story is simple. I was recruited by Sesame Street, you know, the educational program that Begonia was talking about. I don't remember why they recruited me, frankly, about 10 years ago. But one thing I remember, we changed Cookie Monster. Cookie Monster used to eat cookies 7 days a week. And we decided it should be 1 day a week. This had a huge impact on children. They began to ask why. And we told them because health is important. And they began to be very conscious of the importance of health. Now comes the next step. And this began about 10 years ago. The neuroscientists began to understand that whatever you tell a child, because the number of centers in the brain are relatively few, is captured, and it comes out later in life. Where when you go later in life, there are many centers, and whatever people tell us may be chaotic to us. We listen to few things, we escape others, but not children. So if you look at yourself, as I do, the environment that you had in the first 10 years of your life, family, environment, school, you will see that a lot of your behavior today has to do with that time. And because you capture things that come out later on. With this in mind, we decided to undertake the following projects. And that is to instruct children between age 3 to 7 on health. And we started in 3 socioeconomic places in the world, Bogota, Madrid, and we ended up in Harlem, New York, 5,000 children. And we randomized them in 2 groups. The first group, very aggressive, 60 hours over 6 months, how your body works. Child need to understand, you cannot talk about obesity if you don't understand how the food works, enters. It's important, it's critical, they have to understand in order to capture the appropriate healthy habits, food habits, physical activity, and something very interesting, how to control the emotions. We teach them that when they reach age later on in life and they are presented with alcohol, drugs, and so forth, they learn to say no. And actually what we do, we teach them about self-esteem, that we are actually acting by yourself and saying what you think. You should be, your esteem should be high because you are really making a point. This is actually what we teach these children. The other 2,500 serve as controls. We publish a lot, as you see in the slides, but let me tell you the news. Interestingly, and perhaps I would say it worried us, is the first curve here. Let me use the other pointer. You see, we instruct them, everything is fascinating, but then with time, they lose a lot of what we told them, contrary to our hypothesis. Okay, we'll come back to this in a moment. But now comes the good news. The environment, these children in a school that there is intervention, those who were not intervened, they did well. Interesting, the importance of the environment. You are in an environment that everybody talks about health. You don't have to instruct everybody because they really begin to take care of themselves. So this first project has led us to the following projects. And that is, we are learning something now here. Let's go to the first curve. We have now 50,000 children around the world where we are all randomizing the following. We call sustainability. And that is, for example, a child is instructed at age 5, and this is instructed again at age 10. I can tell you the second instruction, the results are exponential. Compare with a child that only you instruct at age 5 or at age 10. So what we are learning, and we learn this in adults too, that anything in our lives that needs some effort needs absolute repeatability and sustainability. So everything, I can tell you that. And we found this in health critical. So now we are very encouraged because we think that in these children, by exposing them 2 or 3 times, we are doing this until age 20, exposing them 2 or 3 times to a very aggressive interventional program is actually going to work. But the concept is very important. Sustainability can only be achieved by repeatability. And this is something that we are learning. That's the second project. The third project is in New York and in Madrid, actually, which is everything I mentioned to you about sustainability, but in much more concise and granular way. For example, we are now trying to learn how the teachers, what motivates a teacher. We try to learn about environmental aspects like passive smoking and so forth, the role of the family. So it's the same project that we are doing worldwide, but in New York and Madrid, in the 5 boroughs of New York and Madrid, we are now trying to understand much more the details. This is the third project. Now, and the fourth one, actually, I thought was going to be a big failure and has been the most interesting one in terms of results. Remember the curves I presented to you, the control group that did well? We decided to work on the environment, so we went into the family. So now we have a project that the 4 aspects that we introduced to children, the 4 aspects I mentioned, are now introduced to the parents, the children and grandchildren, with a different degree of maturity depending on the age in the family. It's a project of 1 year, which is repeated 3 times with more maturity on the 4 aspects. Well, we began to introduce these to people who are working in industry, for example, workers. And the executives feel so happy because you are taking care of the workers. Unbelievable results, I have to tell you. Now what I'm telling you is that the environment where we are is absolutely critical. We are going to deal with health. And this, we have learned this from this study in the children. And I finish by saying to you, sure, I could say education is important, but let me summarize everything I mentioned to you today. We talk about age 20 to 60. The disease is beginning at age 20. By the way, where we learned this? In Harlem, New York. When we did the children in the schools in New York, we did the parents. So the parents are between 24 and 35. And they, about 15-20% had already disease by ultrasound. So I think the disease may start at age 20. I mentioned to you age 60 to 100. Age 60 to 100, you can imagine. We are talking about our brain, and we didn't realize that this might have started much earlier. And then I mentioned to you age 3 to 20, which is to me is the key if we want to do something in terms of the future, in terms of cardiovascular health. So summarizing further, earlier you start, more potential is the benefit and lower is the cost. Later you do things as we do, and we have to. Now, lower is the benefit and much higher is the cost. So I ended up with a title that if you look at, it has changed a little bit from the original title. The red is the same, transition from cardiovascular health to cardiovascular disease, Imagenomics throughout the lifespan, but education through science. What I'm really explaining to you is that science has led us to the last issue, which is education. And that is, this is to us very important. It wouldn't be education without science. But education to me is the future, and particularly as early as you can do it better. Well, I finish here, and I'm happy there are some medical students here because you're going to see a change. It's going to change. We need 5, 10, 15 years, but the movement towards understanding disease as it starts at a very early age, I think is absolutely critical. And I will finalize by saying to you something which I didn't have the time to present to you in detail. We are learning what are the molecular mechanisms that defend us I mentioned the monocytes in the bone marrow, but there are many others. And it's fascinating that if we talk about pharmacology in the future, I see pharmacology evolving by understanding the defense mechanisms and enhancing them. Examples, most of the treatments we use in heart failure today, SGLT2 inhibitors, etc., are really affecting defense mechanisms in giving them a speed. The vaccinations, actually, I'm very good friend with the two Nobel laureates. We are very good friends, actually. And they were funny. They were explaining to us, to my wife and myself, how they started all of these. And they started with mRNA. mRNA was considered to be a consequence of disease. But nobody thought that many of the mRNAs are the defense mechanisms that we had. So the vaccination was actually to enhance the mRNA, which was the defense mechanism. This is actually what actually happens. So I am giving also a sense to you that it's not only education, but it's to learn more and more about health. Look, the monocyte. Can we enhance the defense mechanism in the future, pharmacologically speaking? And I think this is another aspect that I think is quite fascinating. Well, I finish by saying thanks very much, Begonia and the group here for inviting me today. I will be happy to come back if my health permits some other time in the future. And I'm very happy that for the medical students to really, I dedicate this presentation to them and to the young people here. All of you are young. Thank you.